Okay, so now let me go through where we are. We've gone through all the different reviews of the neurophysiology, the physiological web, the lifestyle factors, dietary factors, environmental pathogenic factors, and nutraceuticals. And now, how do we evaluate a patient with cognitive decline? So in this section, I've done a couple things. I made a checklist of things you have to get out of your evaluation when you work with a patient with cognitive decline, which we'll go through step by step. Then I made a chart for you of all the things you need from the history, from the medical exam, from imaging studies, and all the things that are all part of the workup. Now, obviously, when you do an evaluation, you're going to be limited by your patient's budget. You're going to be limited by accessibility to what's available in your region. Like not all the PET imaging studies are available everywhere you go, and what labs are available to you. But you can go through the basic concepts. And one of the difficulties of teaching this topic is, like, we're going to talk about a neurological exam, but we can't teach how to do a complete neurological exam in an hour and a half, or even in a weekend, and it takes a lot of time, or how to do a thorough, complete functional medicine workup and laboratory workup. So I can just highlight bits and pieces of it, and the greater understanding you have with your own background with certain areas, the more thorough you can be with your evaluation. But at least I want to highlight the key things that you need to do when you're working up a patient with cognitive decline. So the clinical objective of this presentation is to go over how to clinically evaluate cognitive decline with questionnaires, medical history, physical exam, labs, and imaging studies. And ultimately, when you're going through your evaluation, remember that there's different stages in progression of cognitive decline. So subjective cognitive decline is, does the patient notice cognitive decline themselves, less efficient, but still can they still can perform all their cognitive tasks. So that's one where you're not as concerned with, but you still want to make sure that you evaluate it thoroughly. Mild cognitive decline is where their friends and family noticing cognitive decline, and they're losing performance. So this has really impacted their work function, their career function, their family life. This is where it gets much, much more serious. And this is where you're starting to see early signs of neurodegeneration. And then when it comes to dementia, this is where there's impairment of activities of daily living. Remember that when you're looking at cognitive decline, there is some degree of normal aging, which you have to account for. And then there's mild cognitive impairment or mild cognitive decline, which is a red flag. And then you finally get into the stages of dementia. And in the severity of cognitive decline, basically of less efficient cognition. This is where you have physiological imbalances, and we'll go over the list of those things. And then as people get mild cognitive impairment, realize that they're probably not going to come with that chief complaint. They're probably going to come with the chief complaint of depression, fatigue, and anxiety. When the brain starts to degenerate, becomes less efficient, it's very common to have fatigue and energy issues. So their primary complaint may be chronic fatigue. As the brain loses the ability to fire, people start to develop depression, and they lose the ability to gate their limbic system, and many times have anxiety. And this is where you're going to have to determine whether you're dealing with an early neurodegenerative disease or just some type of metabolic imbalance or a combination of both. And then if they start to have decline in their activities of daily living, that's when you're going to have to really make sure that at that point they have dementia, and whether it's Alzheimer's disease being the most common, or some of these other variants of them, because that'll change your prognosis and even your treatment applications to some degree, or if it's just metabolic dementia caused by something like congestive heart failure or renal disease or something like that. Now, I put together this checklist, meaning that when you're working up a patient with cognitive decline, there are some things you have to make sure you establish by the time you're done with your evaluation and develop your treatment plan, because you're going to need this information to develop your treatment plan and a way to monitor their care over time and their outcomes. So the first question is, do they have cognitive decline? And then the next part is, what is the severity of their cognitive decline? You can just classify it into subjective cognitive impairment, mild cognitive impairment, and dementia. So if they only notice that it's subjective, and it's not really impacting their function or their work, that's still considered subjective cognitive impairment. If it's impacting their work and their performance and other people noticing it, that's mild cognitive impairment. And then they may have dementia if their activities of daily living are starting to get impacted. And if they have dementia, what stage are they in? We'll go through stages 1 through 7 in a chart. And if they have dementia, what is the differential diagnosis? Is it Alzheimer's disease? Is it vascular dementia? Is it Lewy body dementia? Is it frontotemporal dementia? Is it chronic traumatic encephalopathy? Is it cerebellar cognitive affective disorder, or is it a metabolic dementia caused by things, or is it a mixed dementia with these various mechanisms? So that's how you do a thorough initial workup, understanding the severity of their cognitive decline. So as you go through the checklist, the next part of the checklist to look at is what regions of the brain are involved. Is it the frontal lobe, the medial temporal lobe, the hippocampus, the cerebellum? And in this section, I put together a form that I developed called the Brain Region Localization Form that can help you quickly identify what areas of the brain are involved, and then use that as a post-assessment to see if their function is getting better in those regions of the brain or getting worse. And then another key question you have to ask and figure out during your workup is, what activities fatigue the brain? So when people start to get neurodegeneration in the brain, they get mitochondrial uncoupling, they lose mitochondrial biogenesis, and those areas of the brain where those are happening are going to have less endurance. So knowing what activities fatigue the brain, and especially when you know the neurology of the brain, regions involved, will give you a clue of what's happening with them. And then what symptoms develop when they are fatigued. Some people, when their brain fatigues, they'll get anxiety. Some people, when their brain fatigues, they'll get vertigo. Some people, when their brain fatigues, they have to shut down and take a nap and fall asleep, and they can't do anything. Some people, when their brain fatigues, their arm goes into spasm and their legs and arms get heavy just on one side. Some people, when their brain gets fatigued, they get tingling and numbness over one side of their body, like a hemisensory distribution. Some people get migraines. Some people get floaters. So those are things to know. That's part of understanding neurodegeneration, which we'll go over. And then how long does it take for them to recover once their brain fatigues? Is it a day? Is it 3 days? Is it a few hours? Do they just need to, eat something and they're back, or they're gone for the next few days? So those are things that let you know their endurance of the brain and their mitochondrial neuron bioenergetics. And the other key thing that you have to understand and make sure you establish as you do your clinical workup is to rule out any underlying metabolic conditions like diabetes, anemia, pulmonary disease, hypothyroidism, lifestyle risk factors and dietary risk factors, and so forth. So when we go through the clinical evaluation, it'll be a combination of looking at questionnaire forms, assessing their cognitive decline, doing a thorough history, doing initial clinical survey, observing their movement, their posture, their speech, their social functions, their ability to understand social norms. And you're going to go into looking at labs, then you're going to go into doing a physical exam, and then you're going to order specialty tests, conventional laboratory tests, or specialty functional medicine tests, and then you may even consider imaging. That's all part of doing the clinical evaluation. So to start with, one of the things to do is really start with the questionnaire forms. So this is a chart, and we'll go through different regions of this, but starting with the questionnaire form. And with the questionnaire form, so we have Montreal Cognitive Assessment Form, Brain Region Localization Form, Cognitive Lifestyle Risk Assessment Form. And if you notice they have cognitive decline, that's where you may want to do tests to look at activities of daily living, or to look at the severity of their dementia with these other forms, or you may want to do formal neurocognitive testing, or have it sent out to have formal neurocognitive testing done. Now, within the questionnaire forms that you have in this course material and things we'll go over in this section, there's some questionnaire forms that are called validated questionnaire forms. Validated questionnaire form means that these forms have shown to be effective in research studies to be a validated form, and they're a standardized form that people in healthcare use as a way to assess cognitive function. And these are the Montreal Cognitive Assessment Form, the CATS Activities of Daily Living Form, Index, and the Dementia Severity Rating Scale. So these are your validated questionnaire forms. Now, forms that I put together in the course for you that are questionnaires used to synthesize course information, they're not validated and they're not recognized by the rest of the research world, is the Brain Region Localization Form. This is a form that we'll go over that goes into all the symptoms of different regions. This is just for you to quickly assess what's happening with them, and not to spend 5 hours doing history about their brain, but quickly have them give you the information on a form. And the Cognitive Lifestyle Risk Assessment Form is a form I put together so you can quickly screen for lifestyle risk factors without having to remember everything we talked about in that section of the course. That's just there for you in a checklist to speed things up. So we'll use a combination of these validated forms and these questionnaire forms used to synthesize information in this evaluation section, and hopefully you can use them in your office with great success. And then if you really want to go deeper and really get a very thorough evaluation, that's where you have formal cognitive evaluations or formal neurocognitive testing. And nowadays, there's some where you can have done in your office or remote or refer out to a specialist. And we'll discuss those testing tools as well. So let's start with questionnaire forms. And remember that the Montreal Cognitive Assessment Form is used to just look at cognitive domains. If they have 2 or more deficits of cognitive domains, and they may have mild cognitive impairment. And there's a score. Anything less than 26 on this is indication to you that they have cognitive impairment. If they have cognitive impairment, then you want to see if they have lost any activities of daily living, and to use a validated form for that. So you can use the CATS activity of daily living or the Dementia Severity Rating Scale. And then that will give you a very good clue to what level of severity they have. And then to evaluate each brain region and to evaluate risk factors, you can use the brain region localization form and the cognitive lifestyle assessment form that we put together. So let's talk about the Montreal Cognitive Assessment Form first. So this is the Montreal Cognitive Assessment Form. If you remember, this checks different cognitive domains like executive function, complex attention, learning and memory, language, perceptual motor, and so forth. It doesn't measure social cognition, so you have to assess their social cognition by the ability to act appropriately, follow normal social norms, not offend people, and they have some consciousness of how they interact with people around them socially. But with this form, the first spectral here, I kind of put it down for you and summarize which cognitive domains are being tested by each section of the form. And this is one of these forms that is much, much more effective than the widely used mini mental status examination form. The mini mental status examination form only has a sensitivity of picking up mild cognitive impairment at 18%. The majority of the patients you're going to see in your office are not going to have full-blown dementia. The majority of patients you're going to see with cognitive decline are going to really have mild cognitive impairment. And this form is going to really, most of the people that fill this form out are going to score 30 out of 30 and not pick up their issues. So this is why the Montreal Cognitive Assessment Form is preferred. So the Montreal Cognitive Assessment Form is designed as a rapid screening instrument for mild cognitive dysfunction. Its sensitivity for mild cognitive impairment is found to be up to 90%. So much, much better than the mini mental status examination form. So it assesses the different cognitive domains. The total possible score is 30 points. A score of 26 or above is considered normal. Time to administer the MOCA is probably 10 minutes. Now, if you're going to use this in your form, you can use this form in your office. You need to go and get training in it and get certified in it. And this is important too if you're dealing with medical legal cases, because this is something that the developers of the Montreal Assessment Form have coordinated with the university, where they can actually teach you how to properly do the form, and then you get a certification. And once you're certified in it, that means you've gone through actual training to use the form. It's not hard to use the form. It's pretty self-explanatory. You basically, as you go through the form for the first part, they have to figure out what that 1 correlates to A, as B correlates to 2, and 3 correlates to C, and 4 correlates to D, and they just draw this. Then they draw a cube, and they draw a clock 10 past 11. Then they go through and name the animals. Very, very simple. And then they go through and you're going to read a list of words to them, and they must repeat them. And then you do 2 trials with them. The first trial is successful, and then after 5 minutes, you repeat the trial. And then there's an analysis form also included in your notes that tells you how to interpret this questionnaire form. And then you read digits to them, and you have them repeat them in a forward order. So, for example, read a list of digits. 21854, you have them repeat them in the order, you have them repeat them backwards, like 742, so they can repeat that backwards. They get 1 point for each. And then they read a list of letters. Subject must tap his hand each time the letter A is heard. So you're reading at F, B, A, you should hear him tap, C, so forth. And then they start the calculations from 7s. You can see how many of those they get correct as they go through. That's for attention. And then for language, I only know that John is one to help today, and then the cat always hid under the couch when the dogs were in the room. And then they go through and they try to name the maximum amount of words in 1 minute that begin with the letter F. So you just have them repeat these sentences, and then you have them go through and find as many words that in 1 minute that have the letter F, and see if they can get at least 11 words in a minute. And then if they do that, they get a score of 1. And then you have like similarities between orange and bananas, that they're fruit. So then the similarity between train and a bicycle is what? The similarity between watch and ruler is what? Then you give them 1 point for each of those. And then you just go through with a memory index score and see, you give them these 5 words and you see if they can repeat these words. And then you see if they're oriented to month, year, date, place, and so forth. But that's the Montreal Cognitive Assessment form. So it's included in your notes. If you look at the form and then look at the interpretation sheet, it's pretty easy to do. And then if you're going to plan on using this form, whether you're a health coach or a physician or allied healthcare professional, get training on the form, and then that way you have legal validated training in administrating the Montreal Cognitive Assessment form, and then you can use it in your practice to evaluate patients. So the Montreal Cognitive Assessment form is going to help you figure out one of your goals, which is, do they have cognitive decline? And then from there, you've got to determine if they're actually losing their activity. Once they notice that they have cognitive decline, are they actually at the point where they have dementia? And the key thing is, if they have dementia, is that they actually have some delay or impairment of their activities of daily living. So as soon as you see the MoCA score less than 25, right, 26 and above is normal, then you're going to basically look at this activities of daily living form and see how they score. And 0 means they have no dementia because they have no loss of activities of daily living. 1 to 3 signifies moderate dementia, which is dementia stages 4 to 5, and severe dementia, they score greater than 4. And that's usually in the Alzheimer's dementia scale of 1 to 7. So here you can see the scale of Alzheimer's Disease Association. And 1 means they have no impairment, normal function, and 7 means they have very severe cognitive decline, late stage, and they really have to be under support of a caregiver. And they even have issues with swallowing, and they're very, very progressed. So the activities of daily living form will help you understand what stage they're in. There's also another form you can use that's in your course material. It's just called the Dementia Severity Rating Scale, the DSRS form. And basically they go through and it goes into their activities of daily living, and you get a score of where they're at. So 0 to 18 means they have mild dementia, stages 1 to 3. 19 to 36 means they have moderate dementia. 37 to 54 means they have severe dementia. Stages 5 to 6. This is assuming that, I should say above 0, but anything below 1 above 18 is really related to the severity score. So you get a bigger clue. Now, there's no point to do these dementia severity scales and activities daily living scale unless they have mild cognitive impairment. So don't waste their time. So this asks questions about their memory. This asks about speech and language and recognition of things and orientation to time, and orientation to place. And sometimes you have to have family members help fill this out so you can get a true assessment of what's going on. And just the fact that a family member is helping fill this form out, you know that they're dependent on someone. So they're definitely on the dementia scale that's there. So that is the forms those are the forms you would use to really look at mild cognitive impairment, and then to validate if they have dementia. So with those two forms, with the CATS Activities of Daily Living Index and the Dementia Rating Severity Scale, you're now able to determine if they have dementia, what stage they're in, stages 1 through 7. And that could be very important for you to know, because as soon as they start entering the dementia stage, you have to then start to have a discussion with their family members and with them is what kind of care do you have planned for the future? Because there's going to be a point where they're going to be dependent upon something helping them with their daily activities. And if that's not planned, it can really create a lot of problems for families. So, and even when people start to have mild cognitive impairment, that's significant. You really have to consider that this is a progressive disease, and over a period of time that they may need some type of care, and what kind of care facility or what kind of family options they have to deal with those issues also. Now, as you continue on through your evaluation, you're going to basically then go into now, for these areas here, if they have dementia, what is the difference between all the different types of dementias? You're going to need to do a physical examination history to figure that out. But as far as the forms go, using these two forms, you're starting to go through the checklist, and you have a couple of those important things that have been answered. You also have determined if they have any cognitive decline. Now, as far as what specific brain region is involved, this is a form that took me many years to put together, but I went through the entire literature for many years and looked at all the different symptoms associated with injury and dysfunction in different areas of the brain to determine what areas of the brain someone may have a neurodegenerative issue with. So this is a chart. If you don't remember all the different functions of the brain and what they do, this is just a simple chart for you to look through But just for the most part, the frontal lobe, prefrontal lobe is involved with working memory, attention, focus, concentration, and the motor cortex that's a little farther back is involved with contralateral activation of movement. Then you have the language centers here, and the premotor areas. This is your speech area. This is your motor strip, which you activate motor activity. This is your somatosensory strip, where you perceive somatic proprioceptive input. And then you get back into the temporal lobe, where you have auditory cortex and association areas of the brain where things integrate. Temporal lobe, where you have sound hearing. Medial temporal lobe, where you have memory. Occipital lobe, where you have vision. Cerebellum, where you have calibration of both cognitive functions and movement. And then the brainstem. But they're all listed for you if you don't remember them. Now, this form is going to go through and in 3 pages really give you a really good idea of what's happening in each region of the brain. And the way this is interpreted, the way this form is designed, is if they have no symptoms, they mark 0. If they have the symptoms 25% of the time, they mark 1. If they have the symptoms half the time, 50% of the time, they mark 2. If it's 75% of the time, they mark 3. If they have the symptom all the time, it's 4. And you never want to see 3s or 4s in any section. So this section here is related to the frontal lobe, prefrontal area. So do they have any difficulty with restraint and controlling impulses or desires? Do they have difficulty with making decisions? Do they have difficulty with planning and organizing? These are all involved with the frontal lobe areas, which is involved with working memory. So if you start to see lots of 3s and 4s in this section, then you're really worried about the health of their frontal lobe. And then if you, the question, the frontal lobe section, prefrontal areas expand to questions 11 through 17. And by the way, on this form, if you see R, that's specific to the right region of that brain. And if it's L, it's specific to the left region of that brain. So you might see someone, for example, that has difficulty with analytical thought, difficulty with math numbers and skills and time consciousness, and difficulty with taking ideas, actions, and words and putting them into a linear sequence, and that's all inside with the left. So maybe they had a left brain injury, and that's kind of caught up with them and have this chronic traumatic encephalopathy. So as they get older, they can't do math, they can't keep on time, they can't track time very well. These things have gotten really, really progressed to deal with it every single day. Those are all signs that the left prefrontal area may really be in trouble. So that's how this form works. Then you go into the next section, and this is well with the supplemental motor areas. And then you look again to see if they have 3s or 4s in any of these regions. And this is going to be with muscle tightness and muscle rigidity and stiffness on the opposite side, with motor movement. Broca's speech area, these will involve the frontal lobe, and the ability to produce words and have fluent speech. And this is important too, because if you're looking at someone who has dementia and you see lots of frontal lobe issues in the early stages, then you're probably thinking of, did they have a brain injury? Did they have a brain injury? Is this really frontal temporal dementia? Because in Alzheimer's disease, the frontal lobe doesn't show up until progressed diseases. So if it's early Alzheimer's disease, this may not be a typical thing. That's part of the pathophysiology since it starts in the hippocampus. And this is where you start to think if they have like symptoms of Alzheimer's disease with encoding and the ability to take short-term to long-term memory issues and trying to remember names and phone numbers, that's a problem. And they're showing us some frontal lobe issues. Maybe they have mixed. Maybe they've had maybe do the history and go, oh my God, they had a car accident and hit their head pretty hard in front of their head. At the same time, they're starting to show early Alzheimer's disease, so you get a better presentation of what's actually happening with them. And this is why we spent so much time on the neurology of memory with the first lecture, just to make sure you understood those mechanisms. Then it goes into the parietal lobe. This is where you have perception of where your limbs and body are in space, so you can see if they have any of those symptoms. And then the parietal inferior lobule is involved with things like cognitive functions like right-left confusion is with the left parietal inferior lobes. And difficulty with math calculation involves left parietal inferior lobe. And then things like interpreting maps and looking at symbols as the right. So you can see all L and R's again. These should all be, 0 to 1s are kind of normal, but 4s and 3s are always a red flag. Then he goes into the temporal lobe and looking at the auditory cortex. This is the perception of sound. And then we go into the association areas. And then you get into the medial temporal lobe, and this is the hippocampus. And these are all the symptoms of early Alzheimer's disease. So you want to see if they have any issues with difficulty with memory and locations, and difficulty with visual memory, and always forget where they put items such as keys or wallets or cell phones, or difficulty with remembering faces and difficulty with remembering names. And you can see R versus L. obtaining it with is the right hippocampus or left hippocampus. This is going to be important when we get to treatment when we talk about doing therapy to activate neurons and plasticity for those regions. So that's where the medial temporal lobe comes in. The occipital lobe is involved with vision. And then we get into the cerebellum, and the cerebellum has three different regions, like what's called the spinocerebellum, which is involved with stability and posture, cerebrocerebellum, which is involved with hand coordination, and then the vestibulocerebellum, which is involved with integration with the balanced vestibular inner ear mechanisms. And if you start to see cognitive decline and they have lots of cerebellum symptoms, that's when you might be worried about cerebellar cognitive affective disorder. So this will help you with your differential diagnosis. Usually when the posterior cerebellum is involved with cognitive issues involving the cerebellum, you also get other regions of the cerebellum involved, such as the vestibulocerebellum or the spinocerebellum, and cerebrocerebellum, which is evaluated in the form. And then you have basal ganglia direct pathway. This is where you have slowness in movements and stiffness in muscles. If you start to see the basal ganglia areas involved, that's when you're starting to think that things like dementia with Lewy bodies may be more likely, because remember, dementia with Lewy bodies impacts the dopaminergic centers first, and that can be useful to help you with that. Indirect pathway typically isn't involved with cognitive disorders, and then when people start to have issues with their brain and start to lose activation of the brainstem autonomic centers, you may see some autonomic symptoms that are also listed there. So that's the brain region localization form. So once a person goes through this form, as far as your checklist, now you're starting to figure out which regions of the brain are involved. And trust me, using the form is much more effective and much faster than trying to remember what each function of the brain is in your history and go through it. So you can have a person fill this out before their appointment and really start to get a clue of what's happening with their brain. So remember, Alzheimer's disease can hit the hippocampus first, and then as it progresses, it'll hit the medial temporal lobe. So you can look at the questionnaire form for those symptoms. Frontotemporal dementias are going to impact the frontal lobe first. And then Lewy body diseases will impact the basal ganglia. So you can look for those cluster of symptoms to help you with your differential diagnosis of possible nexus dementia. And if you see multiple areas of the brain involved, that's when you're starting to think maybe they have chronic traumatic encephalopathy or a mixed type of dementia. So it can be very, very useful for you when it comes to a very complete and thorough differential diagnosis. Now, the other part of the questionnaire forms that's there for you is this cognitive lifestyle risk factor assessment form. And this is just basically me trying to take all the information from those meta-analysis and systemic reviews and putting it into one form, so you can just quickly ask you, like, are you sleeping? Are you engaged in mathematical calculations? Are you engaged in cognitive skills? Are you working out? What's your body? How many drinks of alcohol do you have per day? Do you use cannabis? Do you use tobacco? Have you been on these drugs that have been linked to cognitive decline? And have you been diagnosed with any of these diseases directly linked to cognitive decline and dementia risk? And that can quickly assess those lifestyle risk factors for you in your office setting. And then on the last page of the cognitive assessment form, it just has them write down their typical breakfast, typical morning snack, typical lunch, typical afternoon snack, typical dinner, and typical nighttime snack. So you can quickly screen their diet and see they're getting healthy amounts of fats in there. Are they eating way too much sugars and carbs? Remember, dietary-wise, high amounts of sugars and carbohydrates and fats and fried food are definitely going to promote dementia and cognitive decline. And diets really high in polyunsaturated fatty acids and healthy fats are going to have the opposite effect, be protective. So that will then go through and quickly give you a lot of information with those forms that are filled out. And if your patients have cognitive decline, it's a really good idea to have them fill out these forms before they come into your office. So like in my practice, I have patients fill out all their office forms, and I have a questionnaire form where I ask lots of important clinical questions in their history and send that in to me before the first appointment. Because, sometimes I'll schedule time for a new patient exam, and my new patient exams in my office are scheduled for 4 hours. But if I don't have all these forms done ahead of time with people that have cognitive impairments and brain injuries, I'm not even getting to my exam and history and workup because I'm still trying to get the information out of them. So you really want to be able to email these forms out to your patients ahead of time. Make sure they're completely filled out before they come in. Make sure they even email them in before you actually schedule their appointment, because the worst thing that can happen is they come in for an appointment, you don't have all this information, and then if you're trying to get it there at that time, you're really becoming inefficient in the time you have with them. So you want to have all this stuff beforehand so you can quickly screen it and get a good idea of what's happening with them. Okay, now The other key thing is when you're looking at that cognitive lifestyle risk assessment forms, that's when you start to kind of rule out some of the metabolic conditions and lifestyle factors and dietary risk factors as you go through a checklist of things you have to figure out in your history. So these forms can give you a lot of great information. Now, at some point, if the patient fills out these forms, and you're really worried that they do have some significant degree of cognitive decline, you want to get them some formal neurocognitive testing. Then that's when you can organize that. So formal neurocognitive testing provides a validated test to quantify loss of cognitive domains compared to subjects with the same age or sex. And neurocognitive testing is just a very detailed way to really screen for these cognitive domains beyond just these questionnaire forms that we went over. And nowadays they have in-office or remote testing where different companies have these all set up. They can run through the tests in your office. Or even you can even now have tests where you can have it emailed and they do them at home, or you can send it to a formal neuropsychologist or a trained healthcare professional to actually perform a neurocognitive test. And if you have to understand a lot of these cognitive decline issues do become medical legal issues. Like once the cognitive decline goes down, their ability to fill out legal documents becomes a big concern, and their issues with their general function, making decisions, can be very impactful. And if this becomes the point where those are really important, you definitely don't want to rely on some of these questionnaire forms. You definitely want to get formal neurocognitive testing validated, and it's very important to make sure that's done by an independent person outside your office that can quantify these numbers. Okay, so, and this is just a study showing, there's some reliability with doing computerized neurocognitive testing in your own office. That's important. But I think if it's a real issue, then you should just send it out for someone to do independently for you. And then these neurocognitive tests are just going to give you like a rundown of visual memory and verbal memory and various aspects of cognitive domains, and then give you a number as they're compared to people in their age group. And that is a really good way for you to objectify and quantify their neurocognitive impairments. So that's where neurocognitive forming testing comes in. Okay, you probably wouldn't do it with every single person. You just start with screening the questionnaire forms, but then when it definitely is a medical legal issue, or you want to just have independent information done by an outside person before and after treatment, that's where the neurocognitive testing come in. So the assessment forms are a screen, and then if you need to really get some good, more thorough information about their cognitive function, that's where you do standardized neurocognitive testing. Okay. Now from there, from these questionnaire forms, the next part of your clinical evaluation is to do your initial clinical survey. So your initial clinical survey means, the first time you see your patient and interact with them, you already should be doing an examination. So it's not a formal exam, it's just your immediate impression of what's happening with the patient when they first come into your office. So the things that are important in your initial clinical survey is their initial appointment activities. Do they need assistance driving to the clinic? Do they need assistance finding a location? Were they punctual for their appointment? And punctual for the appointment could mean they're just late because they got lost, they couldn't find it, they can't keep track of time. Those are clues that their cognitive function is impaired. Did they remember to bring their new patient paperwork? Do they need, how much, if they didn't, how long does it take to complete the paperwork? Does it take them, 45 minutes to fill out a brain region localization form, where it takes people normally 5 to 10 minutes to fill that out? So those are all things that you want to evaluate. The ability to get to your office and be on time and remember to bring in paperwork is all actually evaluating cognitive function. So that's part of the initial clinical survey. Then initial evaluation of physical appearance. And then there's body composition, overweight, underweight, normal, or athletic. Those are clues to what's happening. Because remember, overweight increases cognitive decline risk, creates inflammation in the brain. Underweight, especially if they have dementia, is a serious red flag. And then are they normal? Are they athletic? How are they walking? I mean, you usually see them walk in. They come in with a cane or walker. They walk with rigidity and stiffness, like Lewy body dementia. Do they have lack of arm swing? Is their arm swing well? Those are important. Their posture, are they slumped over? Do they have camptocormia? Things like Lewy body dementia. Do they have facial tone? Do they have facial weakness or paresis? Do they look really old for their age? Some people, they come in and they're like 50 and you think they're much, much older because they have significant oxidative stress inflammation throughout their life. So that initial appearance is important for you to figure out what's going on with their overall oxidative stress. And if you guys want to see impacts of oxidative stress, just look at some of these pictures they have of people that get convicted of drug abuse, and their facial mug screens that are available. You can see for that drug abuse, they look like 20, 30 years older from heavy alcohol or drug abuse. They get aging spots, they get severe wrinkles, their aging accelerates much, much faster. So if you see that, those things are also happening in their brain. So if someone comes in and they're 50 and they look like they're 65 because they've used alcohol heavily in their life, then you would definitely start to suspect some accelerated neurodegenerative processes. Now, also look for initial signs of metabolic or neurological disease. Do you see any types of tremor, resting or kinetic with movement, or postural when they stand or move with their head or so forth? Do you see any stiffness or tonus or angulation of the arm, like spastic or arm swinging all over the place? Eyelids, lack of blinking. You see that with Parkinsonian or Lewy body dementia, ptosis, eyelid dropping, twitching. Do you see any balding or just general health? This can be underlying thyroid issues. Look at their skin, see signs of autoimmunity, inflammation, aging spots, and the initial interaction. Are they cognitively aware to where they are? Are they socially aware? Are they polite? Are they rude? Do they follow social norms? Do they give you eye contact? Are they motivated? What's their mood? Do they have apathy? So that's all part of your initial survey to just get an idea of what's going on with factors that can impact their brain function. So that's all related to your initial clinical survey. So listen, from the time they, let's say, send you their questionnaire forms for their appointment, ideally, you have that ahead of time, so make sure you have it in your office, and then you do that initial clinical survey, you have a lot of information to start thinking about what the mechanisms are for the cognitive decline. And then from there, you go into your medical history. And part of the goals of your medical history are to go through and diff-die and evaluate brain endurance and identify underlying causes and lifestyle factors and evaluate diet in much more depth than you can get from the questionnaire forms. So as you go through and you're starting to get into the medical history and you've finished all the questionnaire forms, the neurocognitive testing, the initial survey are really going to tell you these things that are all highlighted from the checklist. So you're going to know before you even get to your medical history that what kind of cognitive decline they have. You're going to get some clues about the severity of the cognitive decline, what stage they're in. You're going to get an idea which brain regions are involved. Then you're going to look at the lifestyle form and get a good idea with their lifestyle. So those are all going to be things that are going to be helpful for you. And then during your medical history, you definitely want to expand in all those things and clarify those things in those forms that can help you. For example, they say, they've been diagnosed with diabetes. You might want to expand upon that. They might tell you that they occasionally use alcohol. You may want to expand upon that and figure out, how long they use it for how many periods of time. Are they an alcoholic? Those things can impact brain function and promote neurodegeneration. So you're going to expand on these in your medical history, but then in your medical history, you got to really start to differentially diagnose Alzheimer's disease versus vascular dementia versus Lewy body dementia and all the other forms, and then really start to understand an idea about their brain endurance. And you'll be able to understand the brain endurance also by how they fatigue when you're doing your medical history. Now, remember, when you're doing your medical history, that you're actually doing a neurological assessment. So the ability for the patient to understand your questions and respond to them is a cognitive function. So as a clinician, you want to look at speech assessment during your medical history and cognitive ability during your medical history and make a note of that. So does their speech function at the beginning, compared to the end the same? And if not, it's brain fatigue. Like you'll have some patients come in, they're like doing history with you and they're boom, 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 boom. And as time goes on, they're dragging and they're slow and things are coming out very slowly. And those are signs of brain fatigue. So that's a clue to you that they may have some brain endurance issue. Letting others speak for them, that's a sign of neurological compensation. So usually you'll do history and sometimes the spouse jumps in every other word to help. And you might want to say, hey, can you stop? I know you're trying to give me the information, and then ask the patient, are you able to recall these, or is this kind of a habit as a couple that you guys have gotten used to because you can't recall words? And then you want to be very aware of compensations that take place with family members when they provide history information to you. Slurred words, loss of speech motor integration, that's Broca's area, and they may initially have no problems when they speak, but as time goes on, they may start to slur their words and things aren't as clear. And those are signs to you that their Broca's area, motor areas are starting to fatigue, and there may be some issues there. Difficulty producing words, is also Broca's area. Monotone speech, I'll show you videos of that. Prosody, that's kind of like where there's no pitch, there's no fluctuation of the voice that happens with impaired right cortex. And then patterns of dysphagia or aphasia that can take place, especially as history goes on. So again, when you look at dysphasias being where they can speak, or they're just not as efficient. So here's just a chart of other dysphasias, whether they have problem producing words. Those are the motor strip area, or the ability to perceive words. That's the sensory association center. They keep asking you to repeat the history and they don't understand as time goes on, or even when you do initial history. Those are clues to you that there's sensory association area or Wernicke's area may be involved. So those are things to consider when you're doing history. As a matter of fact, here's the key principle. If you ever find it's taking forever to do a proper medical history, ask yourself why. Are they not understanding what you're saying? Then you think of Wernicke's area. Are they having a hard time processing it? Are they having a hard time recalling it? Are they having a hard time understanding it? Because the ability for them to hear your question, understand it, interpret it, and then come up with an answer, they're all aspects of cognitive function. And then cognitive abilities in the medical history. The ability to impaired attention is frontal lobe. Impaired focus is frontal lobe. Poor recall of events is medial temporal lobe. Poor recall of facts and names is medial temporal lobe. Slow mental speed is just their general synaptic activity. Apathy, the limbic system. Disproportional emotional response, like they just tell you something and they start crying like crazy. That's an exaggerated limbic response. Cognitive abilities, the beginning at the end, again, related to brain endurance. So remember that your history isn't just getting information, your history is a way to assess cognitive function as well. Now, as you go into your medical history, let's first talk about differentially diagnosing, especially if they have lost activities of daily living. And this is where you're getting into the different dementias. So remember, you're only worried about dementia if they get to the point where their activities of daily living are becoming impaired. And in this chart, remember the key clinical presentations. Alzheimer's disease, initially short-term memory. They just can't remember new things like where they put their keys, phone numbers, names of people they just met. Those are the things that happen initially. And as they progress, they start to get their working memory or frontal lobes involved and long-term memory loss. Vascular dementias, remember they have deficits in the region of the brain and they have the stepwise breakdown and acute onset of dysfunction. Lewy body disease, they start to get like rigidity, stiffness, they have hallucinations that they tell you about that they may be having, they have thrashing and act after sleep and sleeping behavior, their exam findings, we'll talk about it a little bit later, but basically they're stiff and rigid. Frontal temporal dementia, personality changes is the major one. They may actually act inappropriate in your office. Parents, family members, or kids could tell you that they're like a different person. It's kind of scary at times. It comes and goes. They have different changes in behavior. Those are really more frontotemporal dementias and not necessarily Alzheimer's disease. And why is that important? Because you guys, if it's frontotemporal dementia, you're going to know that family member that's suffering from this may have some really inappropriate things that take place that they should be aware of as if the disease progresses. You're not going to see that with Alzheimer's disease in the early, unless it's very severe and late stage. But in frontotemporal dementia, that'll be the key thing that's realized there. And then with chronic traumatic encephalopathy, you definitely want to check for any histories of traumatic brain injuries they've had in the past, especially those in which they've lost some degree of consciousness. Because when you get enough impact to the brain where your glial cells really get injured and you get severe inflammation and slow down nerve conduction to the reticular formation, that's when you lose consciousness. And that's very significant when it comes to setting up the stage for tauopathies and things that develop from brain injury. And then the history of ataxia or dizziness or vertigo. Now, a lot of these are going to be screened for by your forms and intake forms to get an idea what's going on. So your big clue, if you're looking at the brain region localization form for early Alzheimer's, it's just going to see hippocampus symptoms and medial temporal lobe. For vascular dementia, your biggest clue will really come from the fact that they just keep deteriorating quickly over a period of time. They have these stepwise deficits. Lewy body disease, you're going to see basic ganglia direct symptoms on the brain region localization form. Frontal temporal, you start to see working memory symptoms first and change in behavior. And then CTE could be very specific to a region or multiple regions of the brain that's involved. The key diagnostic presentations were with short-term memory and difficulty multitasking, that's early Alzheimer's. Abnormal circadian rhythms with scattered sleep, that's Alzheimer's. Jerky, violent sleep, Lewy body disease. Visual hallucinations, Lewy body disease. Rigidity with stiffness and slow movements, Lewy body disease. personal and behavioral changes in early disease, frontotemporal dementia, and chronic traumatic encephalopathy, history of traumatic brain injury, chronic traumatic encephalopathy, brain fog and worsening of cognitive functions as are prime glial cells, stepwise deterioration, vascular dementia, history of diabetes, hypertension, smoking, sedentary lifestyle, vascular dementia, history of ataxia and vertigo dizziness. Those are cerebellar cognitive affective disorders. So also remember age. Age is a big factor in this too. Person that comes in under 40 with cognitive decline, you're probably not going to be thinking of these dementias. You're going to be thinking about, hey, do they have blood sugar issues? The blood sugar not stable? Have they been ruled out for hypothyroidism? They have anemia, they have gluten sensitivity issues, they have sleep issues that are impacting the cognitive function. You're kind of working around these mechanisms. Now, these mechanisms, if they're not addressed, they're going to promote neurodegeneration. And then once they're 40 to 60, that's where you might start to see concerns for early signs of early onset Alzheimer's or early signs of Parkinson's disease or the brain injuries that are caught up with them they had when they were younger in their life. And then once they're 60 and older, that's when the likeliness of actually starting to have some dementia patterns will start to show up. And then once you've gone through and evaluated their various types of potential dementia, or maybe it's a mixed type, which is very common, you're gonna look at brain endurance. So remember, with all these neurodegenerative diseases that start to impact cognitive decline, there are mechanisms that impact mitochondrial function. And if you remember, when mitochondria are not healthy from mechanisms that impact oxygen delivery or glucose or lack of activation or lots of inflammation, these neurons get close to threshold. So one of the things you may want to look at your history as well are these signs of having neurons very close to threshold. So being very sensitive to MSG or electromagnetic fields, or being really sensitive to perfumes and smells or flashing lights or movement, or getting car sick really easy, or fear for minimal reasons, or just any trivial input that really causes exaggerated symptoms or clues to you that their neurons are close to threshold. And when you're looking at the brain region localization form, like here's an example. They say mental fatigue, decreased attention span, difficulty staying focused, concentrating extended periods of time. These are all telling you that their mitochondrial function is impaired. And then they say, hey, when they initiate their arms, legs become really heavy, their arms get really heavy. These may happen especially when their brain gets tired. So those are clues to you that they may have something happening with them. Or the back muscles tire easily, or chronic neck and back tightness. And they may be initially okay in the beginning of the day, but as the day goes on, some of these endurance signs start to show up. And a lot of times when the brain fatigues, the brain can't dampen the autonomic nervous system. So all these symptoms like anxiety and being startled easily and difficulty sleeping and sensitive to lights all start to also show up. So you can identify which stimulants can cause fatigue by looking at the symptoms of the brain region localization form. So if they tell you, for example, movement or focus, attention, concentration are off here, then you just have to, what period of time does it take for this to happen? It might say just being in a computer for a couple hours or doing work can give you a clue. And then these are the metabolic conditions you definitely want to rule out in general with everyone that has any kind of cognitive decline. Are they getting proper sleep? Do they have any blood sugar issues like insulin resistance or hypoglycemia? Are there any signs of neuroinflammation? Biggest sign of neuroinflammation is brain fog, slowness of brain function that's perpetuated by diet or lifestyle that's intermittent. Are there any signs of hypoxia, poor circulation, general fatigue, anemia? You're going to have to do some blood work for that, do an exam. Any signs of hypothyroidism, and any early patterns of neurodegeneration. And then you're going to go into lifestyle factors in your medical history. You already have the assessment form, but remember, these are all the different things that can be a factor in promoting cognitive decline and risk for dementia. We went over in the lifestyle and dietary factors section. Those have all been translated to in the form, so you can look at the form, expand upon those in your medical history as you do your evaluation. And at some point you want to evaluate their diet, seeing if they're, like here's an example of a diet. They're having a protein bar and coffee in the morning, trail mix, protein bar, sandwich, chip, soda, cookie or something sweet, pasta, burger, Mexican food, popcorn. This is a lot of carbohydrates. So maybe they're just eating a lot of carbs. Maybe that will give you some clues as it comes to looking at their lifestyle factors. So when you're done with your medical history and you evaluate their diet and the risk assessment form, then you get into the physical exam. Now with the physical exam, first thing you do is part of your initial survey is look at their body composition. Are they overweight? Are they underweight? Are they normal weight? Underweight is definitely a concern if they have early dementia, because that's a very poor sign for prognosis, and being overweight, especially in their younger 40s and 20s increases risk for brain inflammation and suggests insulin resistance you have to be worried about. So really underweight or really obese is really the worst prognosis. So that's your initial clinical survey. As part of your exam for cognitive decline, you got to look at their circulation. Because remember, you have to have blood flow to the brain to improve neuron mitochondrial function. So you really want to look at their hands. They shouldn't have any whiteness anywhere. This is cyanosis. You see the blueness of their nail beds or whiteness. The nail beds should be pink. They shouldn't be white. They shouldn't be blue. Their hands shouldn't have whiteness and cyanotic activity. When there's lack of blood flow to the distal extremities, you'll also start to see fungal nail growth. And if their hands and feet are not getting blood flow, you can pretty much bet their brain isn't getting healthy blood flow too. So that's going to really impact your neuron bioenergetics, and you want to really evaluate their circulation to make sure that that improves. Best way to improve circulation is to make sure the blood pressure is normalized, and also things like vinpocetine and ginkgo that activate endothelial nitric oxide can be very useful when you have patients that have poor circulation issues. And patients that have poor circulation issues usually have poor brain endurance issues because they're just not getting blood flow and fuel to the brain. And exercise can definitely make a big impact on that. And getting into a regular exercise routine program can make a big impact on their circulation and blood flow. So once you've gone through visually looking at that, you can do a capillary refill time. Here's a video on how to do a capillary refill time.
For the capillary refill test, apply pressure to the distal volar portion of the digit until the tissue turns pale. Once the tissue's turned pale, simply release and count the number of seconds it takes for the color to return to normal. One more time. A negative result or a normal result is when color returns to normal in 2 seconds or less. This was a negative or normal result. A positive result would be if it takes more than 2 seconds for color to return to normal after the pressure is released.
Okay, so you can add this into your evaluation of circulation, visual inspection. You can look at their hands, you can touch their hands, compare their distal parts of their extremities, temperature to their more proximal. You can use a surface thermometer to compare the difference between those two. They should be relatively the same. And then make sure you check the blood pressure. Remember, low diastolic blood pressure is associated with this dementia risk, and high systolic is associated with dementia risk. These things also impact blood flow to the brain, so you want to evaluate those. Do the pulmonary exam. You definitely want to do some at least the very basic, listen to the lungs, make sure they don't have any signs of COPD or asthma or any kind of respiratory issues. Spirometric testing you can do these very quickly in your office. We have a whole module coming up on respiratory issues, where we're going to go over how to really do a functional evaluation of lungs and respiratory systems and how to support those with diet, nutrition, lifestyle. But the very basics, basically, listen to the lungs, spirometric testing. These you can buy devices very inexpensively to look at the total volume, maximum volume output, and then look at their pulse oximeter for their concentrations. You want these levels to be in the 95 to 100%. Something is below that, you definitely want to make sure the lungs are okay. Remember, one of the causes of delirium in elderly people is they have some prime glial cells. They get a lung infection, like a walking pneumonia, and then their cognitive function goes down pretty quickly. You definitely want to look at an eye exam. And if you haven't invested in a panoptic Distance tool, you definitely want to get one. Panoptic allows you to really see the entire retina, the optic nerve, the macula, the blood vessels really, really well. So this is a study that was published called Association Between Recent and Established Ophthalmic Conditions and Risk of Alzheimer's Disease. This 5-year study, they followed almost 4,000 patients over the age of 65, all without clinically diagnosed Alzheimer's disease at the time of enrollment. After 5 years, 792 subjects were officially diagnosed Alzheimer's. The study found that those subjects with age-related macular degeneration, diabetic retinopathy, or glaucoma were 40 to 50% more likely to develop Alzheimer's disease compared to patients without these specific conditions, which makes sense because the changes that are taking place in the eye really share similar pathophysiologies for neurodegenerative diseases. So, make sure you know how to look at the eye. Use the panoptic, it can help you. You can look at the optic nerve. You can look at the blood vessels. You can look at the macula, macular degeneration. You basically have a damaged macula, as you can see here. It's normal, here it's off. With diabetic retinopathy, you'll see hemorrhages and this, cotton wool spots all over the place compared to normal. Glaucomas, you'll see cupped optic nerve, and usually you have vision impairments and scotomas and those things in their history that they may know about or may not know about. But definitely look in their eyes when you're looking at a cognitive assessment. Also look at their mouth. Remember that gingivitis and gum health has a major impact on brain function and dementia and ulcerative disease. See if there's any signs of periodontal disease or gingivitis. Look for inflamed gums. Look for deteriorating bone loss in teeth. These patients tend to have really bad breath when they have these bacterial species that are very high in their mouth. So that'll be another thing to evaluate. And then you get into the neurological exam. And then when you look at the neurological exam, I've also broken it down for you just to kind of summarize some of the key points if you're starting to work with a person that has some dementia type patterns. So Alzheimer's disease, remember, it starts in the medial temporal lobe. You're not going to really have any physical examination findings associated with that. You're going to find that most those patients out with a Montreal Cognitive Assessment Form or with formal neurocognitive testing. Their actual sensory motor cranial nerve exam will probably be normal in the really early stages of Alzheimer's disease, even to moderate stages of Alzheimer's disease. Vascular dementia, the key thing is stepwise global deficit, but it can be, depending on where the little mini stroke is, you can have all types of symptoms. You can have someone wake up with restless leg syndrome. That's a sign they had a little vascular mini stroke. Someone wake up and all of a sudden they have dizziness and they don't know why, and it's not like a benign positional vertigo. It's just an acute onset and had a little mild cerebellar stroke or something. They may wake up and all of a sudden their leg is numb and maybe it goes away after a few weeks, but those are little mini strokes. So those will have different experiences and exams at different times. Lewy body disease, that's when the basal ganglia direct pathway is involved. That's when you have hypokinesia, which is slowness, resting tremor, so they start to have movement and rest, rigidity and stiffness, or they start to have slumped posture called camptocormia. Frontal temporal dementia, the frontal lobe starts to degenerate, so their limb will be really tight, or even if you see patients that have stroke, their limbs in a spastic posture. These people will just have like angulation, they're not necessarily in a stroke spastic posture. They have upper motor neuron signs, like Babinski's or Hoffman's, and Chalmers test positive. We'll go over some of those videos. They may have exaggerated deep tendon reflexes. Chronic traumatic encephalopathy, depending on where the brain's involved, you can see all types of imbalances. And cerebellum cognitive affective disorder, you may start to see signs of cerebellar disease like ataxia, dysdiadochokinesia, or termination tremor. And then with people that have loss of procedural memory, like implicit memory loss, that's when you see apraxia, like you ask them to do this, they can't figure out how to go, like to have them go finger to thumb, every other finger, and they just can't figure out how you're asking them to do it. That's called apraxia. Or if the cerebellum's involved, they may have ataxia or termination tremor. So these are the ways to look at exam findings for different types of diseases. And then for the most part, when you're trying to do a focused neurological exam, when you're trying to rule out the frontal lobe activates the corticospinal tract that inhibits the anterior horn. These are things you'll see with frontotemporal dementias, and these are you'll see spastic or tight limbs, non-fluent speech, deep tendon reflexes that maybe exaggerate hyperreflexia or upper motor neuron signs. And for people that have dementia with Lewy bodies, you see rigidity and stiffness in their tone. They may have a soft tone. The gait analysis may show loss of arm swing or shuffling gait, like a Parkinsonian gait, or they may have rigidity. If people have cerebellum issues, you might see head tremor. I'll show you some videos of that. Or kinetic tremor, meaning tremor not at rest, but when they reach out for something, they get a little bit of tremor. Those are involved with the cerebellum. And they may have imbalances with balance issues, have a positive Romberg's, and also have dysdiadokinesia. When they try to do rapid, smooth movements, they just can't really do them very well. So let me take this exam for you and talk about the frontal lobe first. So remember, with frontal temporal dementia, the frontal lobe is impaired, and this frontal lobe becomes the corticospinal tract, which influences a lot of these upper motor neuron sign symptoms. Now, with frontal temporal dementia, you have two variants. The behavioral variant is the most common. So remember, these are ones that have the personality changes. If you start to see personality changes, cognitive decline, and you start to see frontal lobe examination findings, you're really concerned about neurodegeneration, you definitely want to get some imaging done. Or any kind of aphasia, where they have motor speech deficits, they have a hard time comprehending what you're saying to them, or they just have a hard time finding words, or words are being mispronounced, or words aren't making sense. These are all associated with frontal temporal dementia in your history, okay? And this was the chart of things you'll see with frontal temporal dementia. And the key thing being disinhibition, which is socially inappropriate behavior. They can't dampen their limbic immediate impulses, so they kind of act out in everything that they want to do, and which is very inappropriate. And as they get more pronounced, they like to put things in their mouth and chewing things all the time. They even come in chewing a toothpick or chewing something all the time. That's a new thing that they'll have. And remember, with frontotemporal dementia, it really is that frontal lobe. With Alzheimer's disease, it'll progress into the frontal lobe in very late stages, where in a clinical exam, you want to evaluate that frontal lobe. We talked about the diff dyes between frontotemporal dementia and Alzheimer's disease. Key one being personality deficit in frontotemporal dementia versus cognitive impairment of encoding in Alzheimer's disease. So, when the frontal lobe's involved and you start to get tightness or spasticity, this is an exaggerated pattern you see with a stroke. But for some people, they'll just come in and they're like, the arm will just be tighter on one side the whole time. Or they'll always tell you that they have a frozen shoulder or frozen hip, or arm's always tight at one side. That'll happen when the areas start to degenerate. Also, with different areas of the motor speech areas, you can get something where they have loss of fluency, non-fluent speech. And this may not be obvious for you in the beginning, but as they get tired from doing your medical history, they may have a hard time producing the words. Let me show you non-fluent speech. This is a pretty severe one, but if you know what the severe ones look like, then you know how to look for them when they're more subtle.
See you tomorrow.
Very good.
I want Coke. I want a coffee, please. I want a...
No, I want two.
I want to play
cards.
As you can see, he's having a really hard time producing the words. He understands everything. He just has a hard time activating his motor system to produce the words. With people that start to get frontal temporal dementia, the frontal lobe starts to get declined, it's not this severe, but usually what will happen is you'll just see them getting really tired producing words. And you can see them, like when you ask them questions in their history, they're like, and they're getting their energy put to start to tell you, like, this is what I mean. You can see that level of energy put into producing words. Those are the subtle signs you'll see when the frontal lobes are not working, that effort of like having to now produce the words, or they'll let their spouse or someone else start to speak for them. Those are clues too. And then that's when you want to go in and go, hey, are you having a hard time producing words? Is it really fatiguing for you? Are you putting a lot of effort now to produce words? And if they say yes, you know that they have some frontal lobe impairment. And you'll see those with frontotemporal dementias, or when Alzheimer's disease is starting to progress into the frontal lobe. Another key feature is aprosity, which happens when the right or dominant frontal lobe, which is usually right with 97% of the population, is involved, and they just have no fluctuation of their voice. There's no difference in pitch. It's just very monotone speech. Here's an example.
I was with my friend today in 5th period, and during 5th period, my friend had told me that I had a monotone voice. I went and asked my teacher about it. Well, I asked her about it. She said it was unenthusiastic. Then I went to another teacher, and she too said I had a monotone voice. Is it bad to have a monotone voice? I don't know. I think it's good. I mean, a lot of people like my voice, I think. I don't know. But,
So anyways, that's you see no pitch. It's just kind of like monotone. There's no really change in fluctuation of how they're saying. It's really easy to kind of lose their words, and that is non-dominant hemisphere injury or loss or degeneration. Okay? And you can see with kids that have developmental delays. Actually, later this year, we have a whole course on developmental delays in children. We'll talk about all the different signs that you'll see with them when there are different parts of the brain not developing. So monotone voice, known as aprosity, is something you'll see with people that start to have frontal lobe degeneration. And then, upper motor neuron signs, you're going to see Hoffman signs and a Babinski sign. Hoffman sign, you basically have a finger, you flick it, and if these two fingers come together, that means that somewhere between the frontal lobe upper motor neuron tract is involved. With Babinski's, you stroke the foot and see if the toes flare up. So here's a great video on that.
What you would do here is have her rest the hand and hold the IP joint right here, the DIP joint, and then you just flick the end of the finger and observe the thumb and forefinger as they come a little bit closer together.
Right there. Right there. Right there.
There. And we're going to do Babinski with her also.
See the toes flaring out?
And see how the big toe and toes want to splay out.
If you see that, then you know somewhere from the frontal lobe to the all the way down to cortical spinal tract and the crosses at the medulla all the way down to the spinal cord, somewhere along that tract, something's wrong. People that start to have frontal lobe dementias, frontal lobe degeneration, will start to show up with upper motor neuron signs. So you should be aware of those. And then you will also see with them hyperreflexia. So the way the frontal cortex works, the motor strip activates the cortical spinal tract. The cortical spinal tract has inhibition pathways in the anterior horn, but it's not working well. You start to get these pathological reflexes and things like hyperreflexia. Here's another example.
The first thing I noticed when I checked her reflexes is that she was quite hyperreflexive. So that's C7. We'll do C5 here. C6. She's hyperreflexive on the left side also. So then when I see that, I always check the reflexes lower. And she is very hyperreflexive here. Same thing in the Achilles. So one needs to be concerned with either essential cord compression or maybe some sort of a head injury at one point.
Right, when the frontal lobe's involved, we're going to see both extremities involved, just as you know. And then these are just another review of some things you'll see when the frontal lobes aren't working well. These are these upper motor neuron signs. So there's flaring Babinski. All these just cause extensor toe stretching. They're just stretching the muscles, causing an activation of the monosynaptic muscle spindle, and you get these exaggerated toe extension signs. Whether it's squeezing the calf or stroking the bottom of the foot or stroking the side of the foot, and these are all associated with that upward toeing, which is a spastic reflex. So the other thing you want to do is look at just muscle tone. So you just want to stretch the arms and legs on one side after you check the reflexes. It's an exaggerated reflex there. That's an exaggerated reflex. So you don't really want to see. Now, some people have exaggerated reflexes, but you got to combine it with every other neurological exam finding you have. There's a spastic myoclonic response with her hand. So, like, we know right away her frontal lobe's in trouble just from these examination findings. You shouldn't have any of these examination findings show up. That with cognitive decline and frontal lobe function and things on the questionnaire form with the frontal lobe working will tell you that the person's in bad shape. It's just a jaw reflex. That seems okay. These are other upper motor neuron signs you see with frontal lobe dysfunction. So you can see here, how the fingers are twitching like that. That shouldn't happen. This is,
And showing a positive inverted supinator sign.
and you can see the finger and thumb coming together.
As well as a positive Hoffman reflex on the right side.
Okay. You want to check muscle tone just by stretching the limbs. And check for clonus, just a quick stretch of the foot. So when you quickly stretch the foot, or you can even do it with the upper arms, you should just stretch and there should be no response. If you stretch the foot and they start to bounce back, that's clonus. It's a sign to you that the frontal lobes aren't working. And the other thing is you can just check for passive stretch or see if one limb's really tight on one side versus the other. Those are all the things you'll see if the frontal lobes are involved. And this, if you start to see these examination findings, you should get some imaging because you're probably going to see things show up on imaging. And then if you get into looking at the basal ganglia, the basal ganglia becomes really important for us, especially when we're looking at dementia with Lewy bodies. Remember, when you look at Alzheimer's disease and dementia with Lewy bodies, Alzheimer's disease, the hippocampus is atrophied, but it's normal with dementia with Lewy body disease. But Alzheimer's disease, the dopaminergic centers are nice and healthy, But in dementia with Lewy body disease, the dopamine centers are involved. And when the dopamine centers are involved, that's when you get rigidity and stiffness and mass face and postural reflexes. And sometimes patients come with early Parkinson's disease that develop into dementia. Other times they have, they just come in with dementia first with Lewy bodies. So you want to go through and look at your examination findings. So if they come in with dementia with Lewy bodies first, their first complaint is their cognitive decline, and they progress into motor disorders like Parkinson's, and if they have Parkinson's disease, if their Parkinson's disease continues, then they can get into dementia. The key thing with dementia with Lewy bodies, if you remember, visual hallucinations is a major one, and acting out, vocalization and movements and thrashing around at sleep is another major part of Lewy body dementia compared to Alzheimer's disease, and that rigidity and stiffness as well. And this was the chart we went over with the major differences that are involved with them. Okay, so with dementia with Lewy body disease, early cognitive deficit is impairment of attention, executive function, and visual spatial function. But with Alzheimer's disease, it's just that remembering where the keys are, remembering phone numbers, and things like that. And then again, no visual hallucinations with Alzheimer's disease, and visual hallucinations with dementia with Lewy bodies, and no sleep vocalizations or physical activity with dementia while they're sleeping, but significant vocalization, physical enactment with dementia with Lewy body diseases. So rigidity and stiffness are one of the key features. One of the things that happens when the dopaminergic centers of the brain go down is that you lose your postural reflexes. So what happens is the brain thinks they're falling back. So reflexively, they just bend forward. This is called camptocormia. There's actually nothing wrong with their spine. You also see a shuffling gait. You also see lack of arm swing. If it gets really progressed, in early stages, they won't have tremor. If it gets really progressed, you'll see a resting tremor. And anytime you see resting tremor with dementia, you got to stop thinking about Alzheimer's disease as the main cause, and you have to think about Lewy body dementia. Chin tremor, lip tremor are always features of Lewy body disease. So if you see any of those, you're starting to change your differential diagnosis and go down a different path. Right? So a little bit of a tremor, any of those things are part of the pattern. You also want to check passive range of motion just by quickly bringing the arms, not quickly, but just feeling the arm tone, let them make their limb relax as possible, and then see if there's any tightness or any kind of rigidity. With people that have Lewy body dementia, Lewy body disease, you're going to see what's called cogwheel rigidity. So when you move their arms and legs like this passively, you're going to see them like catch. That's cogwheel rigidity, or it's just going to feel like a lead pipe. You're going relax, 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 and they're just not. Relax, relax, like they go, I am, and it just feels like it's like they're trying to fight you the whole time. That's what's called a lead pipe rigidity. So you're going to see those with Lewy body disease as part of the thing. And then with Lewy body disease, you're going to see hypokinesia or slowness of movement. So here's a person testing.
This all the way open, all the way close, all the way open, all the way close. Faster you can, fast. Faster.
That's how you just check repeated coordinated muscle activities.
Play the piano. Faster you can, faster.
She's pretty good with those. But with Lewy body disease, what you tend to see is instead of doing this, they do this. And it may be good on one side and really slow on another side. Instead of doing this, they're doing this. They're very, very slow. One side could be good and one side could be slower. It usually starts on one side. But slowness of repeated movements is one of the things you see with the dopaminergic centers that are involved, found with Lewy body disease. And then if it gets pretty significant impacts to the vocal system, you can get what's called hypophonia, and this can also progress over the history where they just can't produce enough vocal force.
I started taking lessons when I was a child from ages 9 to 11, and then I put it away for 35 years because it wasn't cool to play the accordion when I was a child.
And are you still playing?
Well, I stopped for the last 4 years since the DBS because I was finding a dyskinesia, so it was like trying to hit a moving target.
Okay, and is there anything that bothers you about your speech or voice?
There's a lot that bothers me. The hoarseness, the volume, the solo. I get frustrated when people keep asking me to repeat.
Okay.
So that's the thing. That's what you'll notice too. Is you'll have them keep repeating. They're just not getting that. They're shouting as much as they can, but they're just not really very loud. And if they get tired, it gets worse and worse. So those are things you'll see with the basic ganglia, right? And then if you get into the cerebellum, where you're trying to see if there's any cerebellar cognitive affective disorder, remember that the cerebellum is now shown to be a major part of cognitive function, and the posterior cerebellum can start to degenerate and get injured. And if it does, that'll have a major impact in cognitive assessments. And if it gets really progressed, you can see normal cerebellums degenerate and atrophy like here, and normal cerebellums atrophy like here. But in early stages, that's you may only see clinical exam findings and symptoms, not see any imaging changes. Now, things like traumatic brain injury, autoimmunity to the cerebellum is very, very common, especially with Hashimoto's people. Remember, thyroid antibodies have been shown to cross-react with the cerebellum. We talked about that in the Hashimoto's course. Infections, inflammation, neurodegeneration, gluten ataxia, gluten antibodies have been shown to directly cross-react with the cerebellum. And when the cerebellum is involved, and if it's involved in the posterior lobe, that's where they'll have these cognitive affective patterns where they have impaired working memory, they have problems with retrieval, they have reduced mental flexibility in switching tasks, they have impaired attention. So it'll be a combination of frontal lobe and medial temporal lobe and retrieval issues. And then usually when one part of the cerebellum is involved, it's just not isolated to one spot. If it impacts the midline cerebellum, which usually gets some vertigo and balance issues, and it affects the anterior cerebellum, and they may have some termination tremor and dysmetria. Now remember, lip tremor is you see with basic ganglia disease, but head tremor is a sign of cerebellar disease. You see these subtle head movements. You ever see that? You know the cerebellum's in trouble. You just see those back and forth head movements, very subtle like that. That's truncal tremor. That's the midline cerebellum. That's impacting the intrinsic spinal muscles through the vestibulospinal pathways. And you'll see that with degeneration or injury to the cerebellum. And then, this is very exaggerated, but you get staccato speech, just like how muscles don't coordinate very well. Speech has a hard time coordinating with vocal cord function, so the speech will be all over the place.
Just say la 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 la.
La 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 la.
Say pa 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 pa.
Pa 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 pa.
Say ka 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 ka.
Pa pa pa.
So you can actually go through different vowels, go e, o, and have them repeat it, and you can see some of those patterns come out. Ataxic speech means their speech is lower than high, and then lower than high. It goes all over the place. You can also see that. And again, a lot of these things will show up in early neurodegeneration, not when you first see them, when the brain's fresh, but when you kind of get through your exam at the end of the day.
But I've noticed too that with my ataxia comes limited options. And
also slurred speech. You know, when people get drunk and they start slurring their speech, it's because alcohol directly inhibits their cerebellum. So slurred speech, fluctuations of speech, like they're shouting, almost like they're drunk. Those are things you'll see with cerebellum findings as well. And then you want to check for balance and stability with cerebellar function. You can just do a Romberg's test where they just stand, feet together.
Arms to your side, hands behind you. I got you. Go ahead and just look straight ahead. Eyes open. And now close your eyes. Okay. Let's try that one more time. Get stable first. Eyes open. Okay. Close your eyes.
See, that's a positive Romberg. So you see that, you're a little bit worried about it. You can check for stability with just tandem walking. Eyes open first and eyes closed. You definitely got to make sure you're next to them when this happens. So they don't fall. You can see she can barely do it. She has ataxia. Patients don't know they have these things. They won't know until you do an exam.
I think you can try with your eyes closed. Oh. Okay, that's good.
Then we test for repeated supination pronation. Cerebrum calibrates smooth movements back and forth.
Back and forth as fast as you can. Fast, 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 fast.
You can see that left arm flailing all over the
Bring it
place.
over there.
It's not very smooth or coordinated. See, it looks like it's bigger movements. That's uncoordination.
Feet together.
And then finger to finger.
Here you go. Finger to thumb. Which one?
The speed of it is frontal lobe. The smoothness of it is the cerebellum.
As fast as you can. And do it on the other side now.
See how she can't really do that as well on that left side. She's thinking can't coordinate it. Her speed's good, which is frontal lobe, but she can't coordinate it. That's cerebellum. Then you can do rapid foot tapping. Speed of this would be the frontal lobe basal ganglia pathways. They're very slow. It's basal ganglia Lewy disease. And if they're having a hard time coordinating it, that's the cerebellum. Because he's a hard time coordinating it. So those are the key things that, we can talk about during the physical exam. And obviously, you could spend many, many hours talking about during a thorough neurological exam. But your goal with the neurological exam when it comes to cognition is make sure if you have dementia, cognitive decline, do you have any frontal lobe signs? Do you have any basal ganglia, dopaminergic signs? Or do you have any signs involving the cerebellum to help distinguish between Alzheimer's disease and dementia with Lewy bodies and frontal temporal dementias, or maybe head injuries or cerebellar dysfunction, cerebellar cognitive affective disorder? Then, you gotta, part of your history, you gotta do routine labs. And obviously, in a course like this, we can't teach you how to do routine labs, but you gotta make sure you do routine labs, make sure there's no infections there that are causing cognitive decline, that they don't have any signs of anemia. You definitely want to make sure they don't have anemia. You want to make sure their immune system is intact. Like you see a person like this, like there's some kind of infection here, they have anemia that exists. This should be, like we got to figure this out if they have cognitive decline. So remember, cognitive decline, the person's very sensitive to any changes in inflammation or any kind of mechanisms that impact oxygenation. So this would be something you would have to address. So routine labs, part of a conditional workup, you have to see what's going on. A metabolic panel 14, in addition, we just showed you CBC with differential metabolic panel 14, Chem 14 or Chem panel, that used to be called comprehensive metabolic panel. They'll just rule out serious kidney diseases or liver diseases, mechanisms and causes for metabolic dementias. You can always measure homocysteine in routine laboratory. Homocysteine elevations can definitely increase risk of vascular dementia, tell you if methylation pathways aren't working. I'd say anything above 10, you'd want to get down below by using methyl donors like B vitamins and folate and so forth. If you want to follow up on a homocysteine test and look at B12 and folate more efficiently, you can do a B12 and folate evaluation. Methylmalonic acid and homocysteine are just ways to look at general methylation pathways, but methylmalonic acid specific for B12, and then 2-methyl citric acid and cystothionine are specific for folate. So if you ever want to distinguish folate versus B12, you can run this B12 and folate panel. They call these the megablastic panel to help differentiate. Lipid panel is always good just to see what's happening with their fats, C-reactive protein, a general marker for inflammation, ferritin, just a marker for acute phase reactants. Ferritin is like CRP. If there's inflammation, this goes up. Okay. ESR, another marker for acute phase reactant inflammation in the body. Remember, anywhere inflammation in the body is going to have an impact. Urinalysis is always good to do to make sure they don't have any urinary tract infections, especially in the elderly population. Urinary tract infections definitely cause delirium and cognitive function issues. And then from there, you get into the whole world of specialty labs, whether you want to add in the gene types, ApoE4 testing for Alzheimer's disease. And remember, the only thing the ApoE allele testing will tell you is if they have a ApoE4 homozygous or heterozygous genotype, that they have increased risk for these amyloid plaque developments happening. Doesn't mean they're guaranteed to have Alzheimer's. It doesn't mean that they can't have Alzheimer's without it. It just tells you they have increased risk. And then, again, we can't spend the time to tell you how to do a complete workup of evaluation of hormones, but hormones do play a significant role. So depending on your confidence and ability, you definitely want to check hormones in males and females. Do your hormone profiles, whether you do it saliva, urine, or serum. That's up to you. You may want to get into antigen testing, especially if the white blood cells are off. Remember, there's different antigens that are associated with dementia risk. If they're symptomatic, you definitely want to screen for it. If you're getting more thorough, in looking for asymptomatic causes, you can also screen for antigens. There's panels like this, where you can just screen for all pathogen antibodies at once to see what's going on, or individual ones based on symptoms. Then you can do follow-up PCR testing to really see what the viral activity is with things like hepatitis or Epstein-Barr. You can check for antigens like mold, whether you do antibody testing, IgG or IgE. Blood barrier testing is something you might want to consider in your workup, because remember, blood-brain barrier permeability impacts Alzheimer's disease and neuroinflammation. S100B is another way you can check for blood-brain barrier permeability. So you can either measure blood-brain barrier protein antibodies or S100B. S100B is found in the conventional labs. See if those levels are elevated Those are associated with blood-brain permeability. You can do comprehensive GI testing, so what's happening with their microbiome. Remember, there's a microbiome neuroglia axis, where inflammation in the gut can impact the brain. That may be something that you may need to address. And your history and your workup and your skill ability is going to kind of tell you where you want to go. And the key thing with Alzheimer's is all these things are all part of the big picture, but it's just, that's why it's, you know, not always easy, and you kind of got to go through it, and whatever your patient's chief complaints are will give you a clue where to start. Intestinal permeability testing is also important. Food reactivity testing, you can check for food sensitivities. You can check for toxic load. You can do toxic load with things like glyphosates and pesticides and solvents. You can check for chemical antibody reactions. And that's where more of the specialty testing comes in. And all I can say with that, with the limitations of time, is let your history tell you where to go. Obviously, if someone comes in with cognitive decline and they have really poor gut function, that's maybe where you want to go. If someone comes to cognitive decline and tell you they suspect they have mold in their home and they're not breathing very well and they're having asthma, when you listen to the lungs, you may want to start with that. If you have a history that they're working around toxic chemicals or solvents, you may want to look at those things. So your history will be a key thing to tell you like where specialty labs to begin with. You don't want to do everything all at once. It's way too much for patients to handle. It's way too expensive for them, and it's ineffective because those things change by the time you can get to them. You know, one of the mistakes that happens in functional medicine is people think the more testing I do, that means the better I am, or the more thorough I am. No, it means you're not effective. So you got to pick and choose these things as your history sees fit. Then you have imaging, and when it comes to imaging, there's structural imaging like standard MRI. You just realize with standard MRI, unless there's severe atrophy of the brain, you're not going to see anything. So most people that have even to the point where they have dementia and who lost active day living, their MRI is going to come back normal. This is where you might have to do a brain MRI with volumetric assessment, where they compare their brain volumes with age-matched controls, and that's how you find neurodegeneration. So you always want to just do a volumetric assessment if you're really worried about finding early signs of atrophy. You're not going to see major change with basic MRI unless they're really progressed. Like here you can see with a normal standard MRI, healthy control, and then Alzheimer's disease, you can see the space between the gyri and sulci are open, the ventricles have enlarged. That's clear brain atrophy compared to that. That's end stage, very progressed Alzheimer's disease. Also though, with brain MRI, you can see vascular dementia very clearly. When people do have these little mini strokes and vascular insults, that can show up in MRI very well. So if you do suspect vascular dementia, you definitely can do routine MRI and see if those are there. And then, you know, here you can see like really progressed frontotemporal dementia with conventional MRI. With cortical basilar degeneration, you know, you can see atrophy all throughout the brain, and especially in the caudate area where the basic ganglia is. And they have their characteristic patterns of atrophy. Here you can see again, same thing. You can see areas around the basic ganglia, insular area degenerated. And you know, these when they get that progressed, pretty obvious. Cerebellar atrophy, you can also see only when it's really, really progressed. So those are your standard MRIs. Then when you look at brain MRI with volumetric assessment, what they're doing is they're really checking their volume compared to everyone else. So this was a study that looked at volumetric assessment compared to regular MRI, and they found that radiologists' traditional approach found with atrophy in only 10% of patients, whereas volumetric MRI found atrophy in 50% of patients. Volumetric MRI was more sensitive for detecting brain atrophy than traditional radiologist approach. Radiologists are just going to look at it and see if they see tumors, lesions, or severe atrophy. What a brain volumetric MRI will do is they'll assess their brain volumes between left and right, like for example, the hippocampus, and also compare it with people their age group. And you can see this little dot, that's the patient, and they want to stay in this white area. Simplest way to look at that. And you can see these different changes in these different volumes with these different types of assessments that are there between right and left and hippocampal volume. And they'll write these in a report for you, and then you can use this as a baseline. You can see they should be symmetrical, and they should be similar to age populations. Those are volumetric MRIs. Very easy to interpret the reports. They're really clearly done, and there's a different version of that. Then there's functional imaging where they do like different types of PET scans to evaluate brain activity. Like these are mostly done in research settings where they can look at glucose uptake, for example, and then compare normal to Alzheimer's disease. Areas that are degenerated are not going to take up a lot of glucose. So these are the special testings there. And then you have functional imaging where they do dyes and scans to actually track amyloid or tau proteins in the brain. There's different studies. These are really done mostly in research or specialty Alzheimer's disease clinics, where they can do amyloid or tau PET scan, or again, a glucose or metabolism scan to see what's going on. And for the most part, the most typical thing that is very valuable to you if you're looking at imaging is to look at the brain MRI for atrophy. But for vascular dementia, standard MRI would be just fine. So when you do your workup, you're going through and assessing if they have SAGE, subjective cognitive decline, mild cognitive impairment, or dementia. And then you go through your questionnaire forms, initial clinical survey, medical history, physical exam, routine labs, specialty labs, imaging. And then as you go through your workup, make sure in the checklist, you've identified these essential priorities. You've identified the severity of the cognitive decline, which brain regions are involved, what their brain endurance is, and underlying cause and risk factors. And if you add this into your workup, you should have a very thorough evaluation of their cognitive decline, and that'll help you when it comes to developing a treatment plan, which we'll talk about next. Thank you.